So I think it's time to start sharing your screen and maybe just go ahead and.
Okay, I'll try my best to share my screen. Wait. Okay. There should be enough people.
Yes, there we go. Is
that okay? Everyone see that? Yeah?
Yes, perfect.
Good. Should we give a few more minutes or be happy?
I think we just start. So today we have Dr. Hassan Malik joining us again from Liverpool. Today's talk will be about the management of complications in liver surgery. Thank you, Dr. Hassan, for joining us, and the floor is yours.
Thank you much, and it's a pleasure. Pleasure as ever. I hope you can all see me and hear me. Over the last maybe 1.5, 2 years, we've had a number of these talks, and we've talked about different things, ranging from primary liver tumors to the tumor board to sarcomas, everything. So what we don't like talking about as surgeons is complications, but actually it's the complications are the things that we learn the most from. So I want to focus a bit about that today, and then I think it'd be nice to have a more broader discussion and share some of our own expertise and cases maybe. Again, this is something I've mentioned before. The major advances in liver surgery have clearly been better perioperative management. A lot of that comes through in terms of imaging, so we can image the liver better, we can know what we're dealing with. The perioperative care for patients has improved as well. Obviously, advances in techniques of liver surgery, so you've seen some of the things I've talked about in the past, but also my colleagues, and maybe minimally invasive surgery, including robotics. The techniques of dividing through livers, etc., have improved. Obviously, training is crucial. So, there's a lot of programs out there which train people to go from being a competent GI, visceral general surgeon, to become a surgical oncologist, and a surgical oncologist with an expertise in liver surgery. So with all that training, which takes years, all this has improved. The days of seeing an operation and doing it the next day are long gone, But despite all these advances, complications will still happen. Now, these are the major complications, that we see in liver surgery. So they can be divided into surgical and medical. And to be honest, the medical complications are the ones that still kill our patients, having a post-operative thromboembolic event or an MI or whatever. And the mortality from liver surgery in Liverpool is around 1%, and that's usually from a complication which is cardiac or embolic. But the one thing that we can perhaps avoid in this list is liver failure. And liver failure is, post-hepatectomy liver failure, I have to say, in most cases is avoidable because it's about better patient selection. It's about augmentation of the future remnant liver volume. So we shouldn't really be seeing small for size livers and liver failure. So that's something that's avoidable. And I'm not going to go too much into the issues about how to optimize a liver remnant before the operation. Perhaps we can pick that up in the discussion later on. Now, so I'm going to focus mainly on the surgical complications today. So if you look at bile leak, well, clearly, how do we manage that as in anything, as a cholecystectomy-related bile leak? If there's a collection, you drain it. You can then deal with the biliary tree itself, either endoscopically, RCP or PTC. That may require something as simple as a sphincterotomy, but it may require a stent. Intra-abdominal collections will clearly, you manage them with antibiotics, but interventional radiology drainage. And most hospitals undertaking liver sections should really have an interventional radiology suite and on-call rotas to support that type of complex surgery. Liver failure, I've mentioned, this is really best avoided, but if your patient develops it, then really the only option is supportive management. These patients are often managed in intensive care, and the only things we can do is to control infections, so do a scan, look for collections, drain the collections, antibiotics, nutritional support. We do not have a liver dialysis machine that works, so it's really supportive care. Sepsis, well, again, source control, again, that equals drainage of collections, dealing with that, but also antibiotics. But the two things which are bleeding and post-hepatectomy biliary strictures are quite specific things around liver surgery, which are separate from all the other things that I've mentioned, which I want to focus a bit more about today. So in terms of bleeding within liver surgery, you know, it's really what I'm talking about today as a tricks of how to get yourself out of trouble. But the best way of getting yourself out of trouble is not to get into trouble in the first place. Now, what I'm going to focus on are these four basic things. So bleeding in liver surgery, perioperative risk identification, how do you deal with this intraoperatively, and briefly about massive hemorrhages. Now, from the earliest days of liver surgery, you know, even when we had liver surgery as a case report from the States, you know, it was associated with bleeding. Okay, in the 70s and 80s, you would have many units of blood in theatre to transfuse during the operation. Okay, and a lot of what we focus on as liver surgeons is about the management of bleeding and the inherent risk of bleeding. You cut into a liver, it will bleed. Okay, it is a very heavily vascularized organ. But we should be able to predict those ones who are at high risk and try and make a plan to prevent bleeding. Obviously, patients who had chemotherapy, and in particular, the sinusoidal obstruction that you see with, for example, oxaliplatin, increases the risk of bleeding. If you're operating on damaged liver with cirrhosis, for example, or someone with portal hypertension, then the risk of bleeding is increased. And if you're going in to do a two-stage resection or a re-resection or whatever, again, these patients will have an increased risk of bleeding, and often the operation will be quite challenging. You'll spend a lot of time dividing lesions before you even start the hepatectomy. You may tear the capsule during the mobilizations. So the operations are inherently more complex, and you need to expect that surgery will be more challenging and more risk of bleeding. Blood transfusion, if you need to transfuse, you need to transfuse, but it'd be nice in oncological surgery to try and avoid transfusion, because we do know that transfusion impacts the immunity, and so there is an association between blood transfusion and disease recurrence. So in Liverpool, for a long time, we were giving iron infusions because a lot of our patients had colorectal cancer with liver metastases. They were anemic due to the primary tumor, and we were giving iron infusions to optimize their hemoglobin before the surgery. Obviously, if they have anemia due to B12 or folate deficiency, we would do hematinics. When we saw the patients initially, we would treat that as well. But this major trial was published about 2 years ago and really found no benefit of iron infusion in patients who are anemic in terms of preventing blood transfusion. So this has gone out of vogue, but if you have, as we have in the UK, I don't know in Egypt, we have patients who are Jehovah's Witnesses who will refuse a blood transfusion whatsoever, then someone like that, optimizing their preoperative hemoglobin by this medical route may be worth considering. The other thing that we can do to avoid transfusion intraoperatively is to use self-salvage. So if you've got a slightly tricky case, you think there's going to be excess bleeding, then using the cell saver machine does allow you to auto-transfuse a patient to prevent the need for additional blood transfusion. And again, in the healthcare systems where the blood can be associated with HIV or Hep C infection, I don't know how good the screening tools are in Egypt for that, but certainly in the UK in the 70s and 80s, they weren't good. And a lot of people ended up with bloodborne infections and died of that. So the self-salvage technique allows you to prevent the need for blood transfusion and also with the modern leukocyte filters, they can be safely used in patients with cancer diagnosis. The other options, obviously in liver surgery, we keep talking as liver surgeons about low CVP anesthetic. Most of the bleeding in liver surgery is venous, so keeping the CVP low is crucial. And if you're doing complex liver surgery, you need an anesthetic team and a theatre team who are comfortable with that. The other thing, which is a newer thing, but has been controversial in the past, but it's certainly supported by a number of level 1 randomized trials, is the use of tranexamic acid in patients having major abdominal surgery, either elective or cancer surgery or trauma situations or whatever. So we would be very comfortable in our patients having tranexamic acid, and there's no evidence that this increases the risk of thromboembolic events. So that's something that I think should be brought into one's practice. Obviously, when you cut through the liver, you'll be using different machines, ranging from Cuisar to Kelly-Clasia to harmonic scalpel, whatever it may be. All these techniques will destroy a few millimeters of liver tissue along the resection plane. They all need experience to learn how to use, and it's important that you're comfortable with whatever technique that you favor, because that technique will minimize the blood loss. But the reality is that each of these instruments can break, and so we all, as liver surgeons, need to be able to use the Kelly-Clasia technique, which is a very basic crush clamp technique that even in Sloan Kettering, Memorial Sloan Kettering, they use as the technique. But it's about expertise and learning how to be meticulous with parenchymal transection, dealing with vessels and all that. Again, another technique liver surgeons use for controlling bleeding intraoperatively is inflow occlusion, or the Pringle maneuver. And this is intermittent cross-clamping of the liver hilum. And this can be quite useful during the parenchymal transection. Using the Pringle intermittently for up to an hour is safe. I think once you get beyond 1.5 hours, then some of these patients will struggle with risk of post-hepatectomy liver insufficiency, especially if they've got established parenchymal liver disease. If you have a tumor around the vena cava or the hepatic veins, then you may need to use outflow control. So this is controlling the vena cava and the hepatic veins, so you can cross-clamp supra and infra hepatically after mobilization of the liver. This may allow you to control catastrophic bleeding. To be honest, it's not something you would routinely do. And just be aware that once you cross-clamp the vena cava, the patient's venous return drops, that become profoundly unstable. So the anaesthetists need to be prepared with decent venous access and be able to fill the patients. But it is a technique in terms of an emergency technique that can be used when you have major venous bleeding from the IVC or the hepatic veins. Obviously, when you do this, you need to put a Pringle on, because you don't want to occlude the hepatic veins in the cava and have blood going into the liver, because then you'll create a Budd-Chiari type situation. So it's what you're talking about here is a complete hepatic isolation of supra infrahepatic clamping, Pringle, and so that whole segment is of cava with the liver is occluded. And so it can be a life-saving technique, but you need a plan to be able to deal with the problem, which I'll come to in a second. Obviously, when you're operating on the liver, you have a lot of kit. So you may need to put a vascular clamp on, as I've just mentioned. You may need to use staple guns. The other thing that we tend to rely on as liver surgeons is hemostatic agents like FlowSeal, which I think you can see my arrow here, FlowSeal here, which I think is an excellent agent to control bleeding from the resection margin. So after the hepatectomy is done, if the resection margin has ongoing bleeding, flow seal is very good. And the other thing is, if you see a focal point of bleeding, then the proline sutures to control that with a stitch often works well. I tend to operate nowadays open surgery with loops. So it gives you that additional magnification to see the bleeding point, and certainly that helps. What about catastrophic hemorrhage? So this reference is around a TV program in the UK, which is probably in the 70s and 80s. And so I'm going to use some quotes from that. So when you get into catastrophic bleeding, the first thing you say to yourself as a surgeon, I'm bloody stupid. Well, how the hell did I do this? You know, how did I get into this? And then your heart sinks because you see this welling up of dark blood, and you think, "Oh my God, how am I going to sort this out?" We're all doomed. You start sweating and you get palpitations, and then you start to panic. You know, so these are all the kind of emotions that you may get. But the key thing is, as a surgeon, you're probably the only person in theatre who has to be, you know, able to control that situation. The anaesthetist can't, the scrub team can't. It's up to you, and you're the one person who should not be panicking. So in that situation, the first thing is to just calm your nerves, to stop, assess the situation. Can you control the bleeding with pressure? This is often venous, so you can control it with pressure. If you've got a split liver and you've got bleeding probably from the middle hepatic vein, can you put a clamp on it? Okay, you're dissecting along the middle hepatic vein, you get bleeding because the side branch is torn. Sometimes putting a clamp on that can just control it. Put on the Pringle maneuver. Can you manipulate the liver a bit more, get better access? So these are the type of things you may want to do. I think it's important in these situations to communicate with the anaesthetic team and the theatre team to make them aware of what's happening so they can get support. Often in theatre, I don't like music in theatre, to be honest. Some of my colleagues do, okay? Ask for quiet. People have to be focused at this moment in time. Sometimes when you're in a difficult situation, there's people out in the periphery of the theatre talking, and you know, they don't realise the seriousness of the situation. So tell everyone to be quiet and focus on what needs to be done, which is ultimately the patient on the table. Get help, okay? Get senior or experienced help from one of your colleagues. It doesn't have to be a liver surgeon, just have to be someone experienced who can come and help and support. And same with the scrub team, and the same with the anaesthetic team. If your hospital has a major hemorrhage protocol, then you can activate that. So that gives you rapid access to blood products. The key thing in this situation is to allow the anaesthetist to stabilize the patient. Because what you want to do by compression, Pringle, etc., is to prevent more bleeding. So that the blood that's been lost, the anaesthetic team can resuscitate and get back into a period of stability before you do anything else. Because whatever else you do, there's going to be more blood loss that's going to happen at that stage. Get everything you need to sort the problem out. There may be sutures, there may be clamps, there may be whatever else. Okay, get it all ready. You don't want a situation that you need something, it's in another theatre, and they send someone from your team to go off and they can't find it. So get everything in theatre before you start. The key thing again here is to expose the area of bleeding. Okay, so in liver surgery, what inexperienced people will do, they'll be partially transected a liver. There's like a tunnel that they're working in. There's bleeding from the distal end of that tunnel. They don't know what's causing it. It's just coming back, bleeding, and they don't have control. So it's important to, you know, open the liver like a book so that you can expose the whole area. You can identify where the bleeding point is coming from, then you can ligate it, you can suture it, whatever you need to do. Expose it well, that's important. And then you're thinking, what you're thinking, where do we go next? And so get a plan of action in terms of how to deal with this. Often what we find is that once a specimen is out, it's very easy to sort out the bleeding point once a specimen's out. But the problem sometimes is that you get into bleeding at an early stage in the operation, long before you're ready to remove the specimen. And that's why, as a surgeon, you need to be thinking 1 or 2 steps ahead. So that comes from experience. It comes from understanding that there's an area here that is risky. I'll do something else, which is safer, and I'll do something else, and I'll do something else, and I'll prepare to come back to the risky part at a moment in time where, I can quickly remove the specimen and then deal with that. Okay, and an example would be like a hyoid-cholangiocarcinoma operation, which I've talked about in the past, where if they need a portal vein reconstruction, I will often have the whole specimen hanging by the portal vein. All the dissection is done. So at the very end, you can cross-clamp the portal vein, resect the specimen with the portal vein and reconstruct. Not try and attempt it at an earlier stage. And if that goes wrong, then you're struggling because you've got bleeding, you don't have good access. So it's about planning ahead. So summary for the bleeding bit is predict which cases are likely to be challenging. But importantly, get the correct team in theatre before the case, okay? If I'm doing a sarcoma, and it needs a vascular resection, not for vena cava, but aorta or iliac artery, or a ureteric reconstruction, I'll get a vascular surgeon in, I'll get a urologist in to do that case. And I often say to them that your job is to make me look good, because the patient knows me, they don't know you, but you're here to make sure that this operation goes well so that I look good, even though you're doing it. I know it's a joke, but it's better that to be prepared for the worst and have a good outcome, that get into trouble and then ask for help. You may do that once or twice, but if you're doing it every week, people say, well, what is this person doing? Okay. Prepare for the worst. Manage and control the blood loss. Have a strategy for massive hemorrhage. Now, the next bit that I want to focus on is the post-hepatectomy biliary stricture, because these are the things that I think surgically are very challenging. Okay. Now, if you've got a post-hepatectomy bile leak, as I mentioned before, you can do an ERCP or a PTC. But often the bile leak is due to a stricture, a distal stricture, and that's why the leak is happening from the resection margin of the liver. And the difficulty is the ERCP and the PTC may fail. And what I really want to focus on at the moment is, what do you do in that eventuality where you've tried an ERCP and a PTC and it's failed? So generally, we're talking about an operation, a hepatocogeginostomy. And the reality is, it never looks like this picture. Okay? This is someone who's had a bile duct resection for a colodocal cyst. You've got a nice, beautiful biliary anastomosis, really clean, okay? But in the situation where you've had a previous hepatectomy, so right hepatectomy, and you've got a complex stricture, you do not see this anatomy. The liver, as the hypertrophies rotates, she'll spend hours getting to the liver hilum. And then when you get to the liver hilum, we expect to find the bile duct, which is most anterior. Actually, the most anterior structure is the portal vein, because the bile duct is rotated round to the back. And the stricture may be partially intrahepatic, so even dissecting the hilum will not get you to the actual bile duct or the left hepatic duct, for example. So yes, we can do a hepatocogeginostomy. or segment 3 bypass or whatever. But these are very challenging. And what I want to describe is how to get yourself out of trouble, but in a different way. And this is a paper that we wrote, and it was published in the European Journal of Surgical Oncology, and Dirk Groenhagen from the Erasmus Center in Rotterdam was my fellow at the time. And he wrote this paper up. I was the senior author. So this is a picture. You can see PTC drain and the left hepatic ductal system. And there's a surgical, in fact, there's a radiological drain here, because the patient had a combination, as I've mentioned, of a stricture and a bile leak. And they had repeated attempts at PTC, ERCP, all failed. So this is what we did. So laparotomy, it's easy. You don't have to mobilize the liver. You open the abdomen, and the first thing you see is a PTC going into the liver. We're sitting right in front of you. This is a picture of that. So the next thing we did is we create a hepatotomy using the Cusar and excise a wedge of liver, but carefully ensuring that we do not avulse the PTC. You follow the PTC down, and you keep following it down until it reaches one of the intrahepatic ducts, and you can see that in the arrow. And this is it in the picture, in the schematic. And then we put a rulum onto that, doing anastomosis, like this. So I've had to do this 3 times in the last 15 years. And in all 3 times, the patient left hospital without a PTC drain, with bile getting into their gut. So dealt with the biliary obstruction, they were no longer jaundiced. And so it's an effective alternative technique, getting yourself out of trouble in that situation of a post-hepatectomy hilar stricture. So just a different way of approaching that. So what I want to kind of say in conclusion really is what differentiates an ordinary from an expert centre. It's not often a surgeon. There are plenty of very good surgeons working in ordinary centres. What differentiates an ordinary from an expert centre is this concept of a failure to rescue. Anyone can operate on the liver or whatever else, but when you have that complication, it's that ability of you and your team and your hospital to be able to rescue the patient, to deal with the catastrophe, to allow them to survive, and then hopefully regain full health. And often this failure to rescue is associated with centres who are low volume or less expert centres, because they do not have the knowledge to deal with these complications, which are treatable effectively by some of the skills and ideas I've just mentioned. And to finally wrap up, you know, good decisions come from experience, and unfortunately experience comes from bad decisions. And I've made plenty of bad decisions in my life. I still recall those cases, but the key thing is that you learn from those and move on and do it better next time round. And you know, you're never too old to stop learning. Thank you very much.
Thank you, Dr. Hassan, for this talk. Let's see if we have any questions from the audience. Please, if you have a question, raise your hand. I have a question. What is your preferred method of transection of the liver? What do you usually use?
Wait, I'll just stay unmuted then. Cusar. So I tend to use a Cusar, which is something I trained on but the Kuzar is very operator dependent. It's not easy to learn. I also use a combination of the tissue link or the acromantis with the Kuzar. That's probably the Kuzar's good, but it's not very hemostatic. It's a very good dissector, but it's not very hemostatic. The hemostasis for the Kuzar comes from the diathermy tip on it. So I'd only use the Kuzar with the diathermy attached. The acromantis is quite nice. It gives you a bit of extra hemostasis. With that combination, we're often doing the operation without any Pringle, any Halar clamping.
Okay. Dr. Medhat Khafaga?
Thank you, Dr. Hassan, again for your very valuable talk. We usually avoid blood transfusion in these cases by taking autologous blood donation from the patient, so long as the hemoglobin is 10 or more gram.
Yeah.
We start by taking 1 unit 2 weeks before operation, and every week 1 unit, and then the day of surgery or the day before surgery, we take another unit. I am using that technique of autologous blood donation since 1983 when I saw it done in Johns Hopkins Hospital. And it's very valuable, really. And usually these patients are not anemic, like colon or stomach cancer. And so we avoid that. We avoid blood transfusion. As you said, it decreases the cure rate. And also there is a big problem with massive blood transfusion too. That's my comment on this.
I agree. I mean, it's not something that is common in the UK, but it's an alternative technique. I mean, I think the cell salvage is good, but the problem with the cell salvage technique is that it's not good in a massive hemorrhage scenario because you don't have enough to go back in. So having blood available is useful, whether it's the patient's own blood or donated blood. But the key thing and the key message here is to try and avoid the need for blood in the first place, and that's by having trying to predict the difficult cases, trying to have the right team with you, using all these tricks in terms of low CVP, higher clamping, outflow clamping, whatever, to try and minimize the blood loss, and then hopefully have a good outcome. But in a situation where you have the catastrophic bleeding, and I've had it myself, the key thing is to get help and to have a plan, you know. And the worst bleeding that we see is from the vena cava, and it is bright, is oxygenated blood. There's a bright red blood that comes back, is coming straight out of the pulmonary arteries, coming straight back from the lungs through the right heart into the sucker. So I completely agree. Yeah.
Also, we also do hypotensive anesthesia, and during the operation, the whole operation. The mean blood pressure would be around 60 or something, and this will lower the amount of blood. We use that technique in all bloody operations. As regards cell saver, I observed that I was trained in Memorial Sloan Kettering Cancer Center for 3 years. I was a resident and fellow in surgery. They don't use the cell saver because I don't know, they have very minimal blood transfusion. Yes.
Yeah. So
they don't use it at all.
Traditionally, cell salvage wasn't used in cancer operations because the risk of
metastasis.
But the modern leukocyte filters, what we've been told, are safe. So that's why it's something that's used. Obviously, if you've got a contaminated field with GI contents, or if there's pus or something else, then we obviously don't use a cell salvage. We would use a normal sucker and things. But it's just a trick that you can, or not a trick, it's an additional device that you can use to minimize. I think the key thing is to try and prevent blood loss. But if you have the options of cell salvage, of tranexamic acid, which is a thing that I think increasingly we should be using, the autologous transfusion, of course, that's another option as well. So these are all options.
Thank you.
Okay. Do you have any other questions? Please, if you have a question, raise your hand. Okay. Okay, it seems like we don't have any more questions. It was a straightforward talk, I guess.
Yeah, it was the type of thing that needs we do need to talk about, because ultimately, it's you have to look after the patients. You have to, you have to be aware of the complications, the risks. You need to then. There's a question coming in.
Yeah.
You be able to know those risks and to be able to deal with them. I think the biliary side of things, the Kala stricture, is something that's very few people talk about, and I've not seen many techniques described beyond just hepatic angiogenostomy, and certainly it's one of these things that is, in that situation, is very difficult to do when you've got a previous hemi-liver resection and rotated liver, abnormal anatomy, fibrosis at the hilum, which you can't access. So it's not easy to do, whereas this technique with the PTC is much more.
Okay, I think we have a question. Dr. Medhat again.
Yes. How often do you use the liver dialysis machine in your practice, and what's your results for that?
Yeah, so this machine that has been used, or we don't really use it in our intensive care at all, and I'm not aware of any evidence. I mean, basically, it gets rid of the ammonia. It kind of reduces the encephalopathy a bit, but I'm not aware that it improves survival. So there really isn't much you can do there. The one thing with the patients in the post-hepatectomy situation where they've got a very high ALT, they become quite unstable, their lactate is going up, they're on increased inotropes, their sugar are down, so the liver is unhealthy or dying. The one thing that I didn't really go into much detail about, because obviously it could be small for size liver situation, but the other thing that you can have is an acute ischemia to the liver, an arterial or a portal venous thrombus. This is more seen in patients who are having a vascular reconstruction. So the one thing to perhaps do is to do a duplex scan of the liver in that situation sooner rather than later to see if there's an ischemic issue or a vascular issue that perhaps you may be able to revascularize. So if you've got a portal vein anastomosis, do you need to redo it or something like that? But that's a very rare situation, and it's often not very successful, unfortunately, because by the time their biochemistry is that bad, the liver is gone, and the patient won't survive.
Okay. Did you do an emergency liver transplant for cases which develop liver failure?
So Liverpool is not a transplant centre, so we don't do liver transplant in Liverpool. But we will not get an emergency transplant in someone. So someone's had an operation for a liver cancer, which is usually what we operate on, and they go into liver failure. They will not be offered a transplant because usually the indications for liver resection are beyond the transplant criteria. So we wouldn't be able to just salvage transplant in the UK. There is a liver trauma setting where someone's had a catastrophic hepatic injury and you've essentially done the equivalent of a hepatectomy and done a portal cable shunt and tied off the hepatic artery and the bile duct and sized the liver, then yes, in that situation, then the patient would be put on a super-urgent list and transferred and listed. But in my experience, that's we've never faced that in the trauma setting either. But no, we would not normally do that situation. Maybe years ago, when I worked in Leeds and things, people would get that, but the regulations for transplantations are very tight. that you can't just suddenly take an organ and give it to someone.
Thank you.
Walid Akmal.
Yes, hello, Dr. Hassan.
So
Yes, thanks a lot for your wonderful presentation. I would like to ask you a little bit relevant question regarding your experience with hepatic hemangioendothelioma, because we faced such a case today in our institute. So what's your experience and what's your best approach and management plan? Do you prefer angioembolization to be followed by resection or transplant?
yeah, so these cases come through our sarcoma tumor board. So I've resected a few cases through the kind of sarcoma tumor board, and these are patients who've often got pulmonary metastases and extrahepatic disease. And so for them, even in the presence of extrahepatic disease, I think a resection seems to be sufficient. So certainly surgery is something we would go for. We've rarely embolized them preoperatively. I guess if there's significant liver replacement by tumor and no extrahepatic disease, then that might be one of those rare cases where a transplant option may be considered. But again, we're not a transplant center, so we wouldn't make that decision. We defer it to Birmingham or Leeds, for that opinion. But I've done resections on 2 or 3 of these cases through the just through my sarcoma practice, which is about 50% of what I do.
Okay, and what's the prognosis for those cases after resection?
It's with sarcomas, all types of sarcomas, the prognosis is not too bad. I mean, you're talking about 50% maybe survival, something like that. I mean, sarcomas behave in a different way. So obviously you have the GIST liver metastases do really well because they respond to Gleevec, and you would resect them and then they'd have adjuvant treatment. So they're probably the best prognosis. We've done a few resections for leiomyosarcoma metastases and things. So they do okay as well. And then you've got these other rare subtypes of sarcomas. So I think, but again, my experience is a handful of cases, so I can't quote the literature and things on it, but my impression of sarcomas are biologically they do better than other cancers we've managed, like, for example, HCC or cholangiocarcinoma.
Okay, thanks a lot.
No problem.
Dr. Gamal Amira.
Hello, Hassan. How are you?
Hi there.
Thank you for the lecture.
No problem.
My question is, what is the commonest cause for hepatocellular carcinoma in England? Is it alcoholic cirrhosis or virus B?
Yeah, it's mainly being overweight. So in the UK, the biggest cause now is no longer alcohol. It's NASH, so some non-alcoholic steatohepatitis. So there's NASH, and there's kind of patients with diabetes, obesity, these type of things. So this is the increase. This is now the highest level. Alcohol is still significant, yes, but I think because of cultural changes and things, maybe getting less. In terms of hepatitis, well, hepatitis C in the UK will be cured soon because everyone's being treated with antiviral treatment. So that's so the high-risk populations for hepatitis C are being wiped out in terms of hepatitis. So they're all being actively eradicated. Hep B is not as big an issue. They have kind of certain communities in the UK which have a higher incidence of Hep B, for example, but it's less frequent. So the commonest causes is obesity, diabetes, all this, metabolic problems.
Do you use the technique of partition of the liver and you use this technique?
No. So ALPS is a kind of controversial technique. I met the German surgeon who described the paper. He wrote the paper, the abstract. He was the first author on the abstract, which went to the EHPB in Cape Town many years ago. And he was involved in the ALPS registry and things. So the thing with ALPS is that there's it's associated with a lot of morbidity and mortality. And we have other approaches, the two-stage hepatectomy, portal vein embolization, hepatic vein embolization, combination of resection ablation as a one-stage hepatectomy. All of these are associated with far less morbidity and mortality. In the ALPS registry, the mortality fell from 14% to half or whatever. But the mortality for colorectal liver metastases in our hands is less than 1%. So ALPS we think is too risky as a technique. If you look at the ALPS registry, they really are only reserving it now for colorectal liver metastases. They're not using it for cholangiocarcinoma and other types of liver cancers because of the risks. So it is an interesting technique. Some centres use it more than ours, but in Liverpool, we've never done an ALPS, never needed to do an ALPS because there are these other options that we have. I'm aware of the Scandinavian study which looked at ALPS versus two-stage and found that ALPS was superior in terms of getting to the definitive second resection. But the mortality rates in both arms in that study was still very high, much higher than what we would expect. Or, so to us, yes, it can be done. But if your radiologist can do a segment 4 embolization, yes, as well as the right embolization, you really need to do an ALPS.
Last question, but away from the lecture. In cases of metastatic colorectal carcinoma, when they are multiple or bilobed, we start with neoadjuvant chemotherapy, yes? When you get complete response in some of them, do you consider this enough that you don't go to remove them? With complete response of some of them.
Yes. Remember, I came to your meeting about 3 years ago, and we had a discussion on this with one of the American.
Yes.
So pretty much our protocol for metastatic colorectal cancer, unless you got a solitary metastases, pretty much everyone gets chemotherapy. And when you have chemotherapy, especially if you've got smaller metastases, half centimeter met or something like that, there is a risk that they will disappear on imaging. And we're talking about very good imaging. We're talking about a liver MRI with diffusion weighting. We're talking about PET, etc. So it's not just a CT, triple phase CT. So if it's not visible on MRI, then in our own experience, and we've recently submitted a paper which has been accepted with the European Journal of Surgical Oncology, so it'll come out soon. We find that in those lesions which have disappeared on imaging, in about 25% of cases with surveillance and follow-up, they will recur. And when that happens, you can obviously still treat them with ablation or whatever. So to me, the disappearing liver met is a bit like the watch and wait policy for rectal cancer following radiotherapy. If there's nothing to see, we will continue to observe it, and if it comes back, we will deal with it. So when all the lesions have disappeared, that is not a clinically difficult situation because there's nothing to see, there's nothing for me to operate on. I will do an internal MRI within 3 months and a CT, and I'll monitor the situation, and if something comes back, we'll deal with it. I think the difficult situation is when you have a mixed response. So some lesions have disappeared and other lesions are still visible on imaging. In those cases, you're going to go in and intervene. Okay, you're going to do a laparotomy or whatever. And then we will do a very careful intraoperative ultrasound. We'll try and see the original sites of disease. If there's nothing to see on ultrasound, there's no scar, there's no nothing, then the option is either to resect that site. Now, obviously, if that site is deep in the right liver, then doing a right hepatectomy for a disappeared met is, to me, nonsensical. Or you can ablate the site, so try and imagine where the lesion was, and then look at the landmarks of the hepatic veins and things, and try and do a percutaneous ablation, or sorry, surgical ablation, or just leave it and just remove the things that you are there to remove. You can't see anything else, and then just do an interval scan. And if that lesion recurs, then you can treat it at a second stage with ablation or whatever else. So that's my kind of logic to disappearing liver metastases, especially in the era of really good quality modern imaging, i.e. MRI scan with diffusion weighting.
Thanks very much. Thank you. And we hope to see you soon.
I think we have one last question. Mustafa.
Thanks, Dr. Hassan, for this nice talk. There is a special precautions or preparation for patient with advanced liver, severe fatty liver, preoperative?
Right, so it's an interesting area because we do see obese patients who have very fatty liver. We less commonly see chemotherapy patients with fatty livers because most of the first-line chemotherapy in the UK is oxaliplatin. So TCAN, which causes the steatohepatitis, is less commonly used in the UK in first line. So it's less of an issue. But in the morbidly obese patient with the fatty liver, the question, I guess, what you're asking is, can we do anything to reduce that risk? And within the bariatric surgery community, they do use a specific bariatric diet for like 5 to 7 days before the operation to make the liver less fatty, removes all the glycogen from the liver, makes the liver easy to manipulate during the bariatric operation. So theoretically, diet can be used in the situation, I agree. It's not something we do in routine practice, I have to say. Your liver MRI, if you use a liver MRI or even a CT scan, but MRI more sensitively, will give you a quantification of someone who's got a very fatty liver. So yes, in that situation, someone who's got the high risk for steatohepatitis, obesity, chemotherapy, whatever, and on imaging they have a very fatty liver, then yes, theoretically one could use this type of diet, but it's not something we've used in practice. And what I don't know is whether or not the diet that we use for someone who's got obesity-related steatosis in the liver will work in someone who's slim, who's got chemotherapy-related steatosis in the liver. You see, I don't know if biologically they would work. But yes, theoretically the diet may help, but we don't use it routinely.
Thank you.
Do we have any other questions? Please, if you have a question, raise your hand. If not, then I think that was it.
Well, it's a pleasure as ever. I have to say I'm running out of things to say.
I'm sure you'll figure out something.
Next time, okay. Listen,
Okay,
enjoy the beautiful evening in Cairo, and inshallah I'll see you soon.
thank you, Dr. Hassan, and good night, everyone. Bye-bye.